In Chapter 7, Part 1, we'll discuss assessments, and we'll begin with biochemical assessments. So biochemical assessments, right, this is just a fancy word for saying we're going to take a look at somebody's lab report. So lab tests are ordered for several reasons. This can be things such as diagnosing diseases. So for example, if I believe you have a bacterial infection, I check your blood, there's presence of the bacteria. Aha, I am correct. It can be used to support nutrition diagnoses, including inflammation or malnutrition. We can monitor medication effectiveness. One of the most famous examples of this is probably going to be warfarin or Coumadin, which is a blood thinner, and we can monitor your PT or INR, which tells us how quickly your blood is clotting. And again, we can follow up, so again, this can be part of our nutrition care process. So again, if you've been diagnosed with iron deficiency, I change your diet, I need to follow up and check on, you guessed it, your iron levels. So laboratory assessment involves comparing a sample from the patient with a predetermined acceptable value. And so what that is our labs have a reference range, or what's normal for most humans. And so some of these labs can actually have quite large values. Some of these have very, very narrow values, where again, looking at the compatibility with life and human health, right, it's a very, very narrow range. But again, the idea is that we want to compare this to some kind of objective standard. So lab values are considered objective, which is they're not interpreted in the sense that it's not feelings or I feel like or some, I have this feeling or inkling. It's a number. And we compare the number to the standard, and it's either above it or below it, or it's acceptable. Now that being said, we do have to kind of take into account when evaluating these lab values when the specimen was collected. So for example, especially when looking at hormones, hormones actually do have cycles, and so depending on the specific hormone, this can be a circadian cycle, this can be a 24-hour cycle, this can be a 28-day cycle, etc. So you've got to consider when the specimen's collected, looking at the current medical condition, so is there anything within the condition itself that would be affecting these labs, looking at any medications that could have side effects that could affect lab values, the patient's lifestyle, age, hydration status, and if they've been fasting. Now with our specimen types, there's several different ways we can look at these samples. So there's whole blood samples. Now you may have seen, if you've ever seen test tubes, you'll notice they have different rubber caps that are color coded. And what they're color coded for is because they have, there's other, I hate to say this, there's other things, but in this case, right, there's other chemicals in the test tube. So for example, and I'm just making this up because I don't know the code, but I'm not a phlebotomist, but for example, if it has a blue stopper, then that is for whole blood, and it will have an anticoagulant inside of the test tube so that when you add the blood to it, the blood won't clot. And so here the entire contents of the blood can be evaluated. So this can be looking at red blood cells, white blood cells, and platelets with nothing removed. Now they could also want to check on serum. And so serum is obtained from blood after the blood has been clotted and then centrifuged to remove the clot itself and the blood cells. And so it's this kind of this honey-colored fluid that again contains specific proteins. Then there's also plasma. So this is the transparent liquid component of blood. So this has water, some proteins, electrolytes, and clotting factors. And so again, this would also be then collected after the blood has separated, and again would be in a different type of test tube. Again, there is a system that we don't really need to be familiar with as dietitians, but we, the healthcare community, do have a system, right, for monitoring this and then examining each different type of sample. So looking specifically at blood cells, so these are separated from anticoagulated whole blood for measurement of cellular chemical concentration, which is a fancy way of saying we want to know how many of these are actually in our blood. And so we do this by measuring the amount in the sample, and then we can estimate this to the rest of the body. So we have our erythrocytes, which is our red blood cells, and our leukocytes, which are our white blood cells. We also have blood spots. So this is dried from whole blood from a finger or heel prick that's placed on paper, and then we can use this, and we're specifically using this for hormone or metabolic disorder testing. So this is quote-unquote the newborn screening. They use the heel stick and dried blood spots. Other specimen types, so we have urine. So again, here we're looking at excreted metabolites through urinalysis. Looking at the feces, so especially for nutritional analysis, if we're looking at malabsorption disorders, this is going to show up in stool samples. And then other tissue samples, including scrapings or biopsies, again for specialized conditions, for example, things like celiac disease, where we may be looking at a biopsy or scraping from the intestines, etc. Less common specimen types, so we'll refer to these occasionally. You have things like breath tests. So these are used to evaluate nutrient metabolism, especially sugars such as lactose. So we're going to look at the cellular breakdown of those products, or the excretion then of hydrogen ions is typically what we're measuring in breath. Looking at hair and nails. So again, hair is particularly useful in assessing trace element levels, so looking at exposure to toxic metals. Saliva can be used to evaluate adrenal stress and hormone levels, so things like cortisol. And sweat can be used to detect cystic fibrosis. Now within our test, we have the fancy word for these lab tests is our assays. Now we have static assays and functional assays. And most of the time when you're thinking in your head of an assay, you're probably thinking of a static assay, which measures the actual level of that nutrient or whatever molecule you're looking at in the specimen. So this is things like serum iron, which is I take the blood sample, I analyze it, and I say how much iron is in this blood. On the flip side, a lot of measurements that we use are what's known as a functional assay. So this quantitatively measures a biochemical or physiological activity that depends on the nutrient of interest. So serum ferritin helps us assess how well your body is using iron and how much iron you have in your body, but I'm not actually measuring iron. Right? So the static assay is the actual amount of iron. Functional assay, serum ferritin, right, is a protein involved with iron and can tell us about your iron status, right, and how effectively your body is utilizing, absorbing iron, etc. But I'm not actually measuring the iron when I look at serum ferritin. Now looking at our interpretation of routine medical laboratory tests. So we have different types of chemistry panels that we can look at. So, and we'll go through there's some diagrams, but in essence, sometimes you'll have a patient will have all of these ordered. Sometimes they'll only have partials. They'll only have specific labs ordered. But these are kind of the standards, and we'll go from there. So you have the basic metabolic panel, or BMP. Then you have the comprehensive metabolic panel, or CMP. We'll also talk about complete blood counts, urinalysis, which you'll see written as UA, and how to interpret hydration status. So first we have the basic metabolic panel, or BMP, also referred to as the Chem 7, and this includes the electrolytes sodium, potassium, chloride, and then either bicarb or CO2, and that has to do with blood acidity, glucose, creatinine, and BUN, and may occasionally include calcium, because I know you're doing the math going, wait a minute, so sometimes it includes calcium. So here we have what's known as the fishbone. So this is a specific pattern that this is written in. And so especially when labs were written by hand. So it's a little bit different now because we have computers. But again, there are still places that do charting by hand. And what you'll often see is that physicians will chart by hand and then have a scribe or someone will then transcribe the information for them and then copy it into the system for them to save time. So this specific pattern known as the fishbone, the labs will always be in this pattern. It always goes sodium, chloride, BUN, and on the bottom, potassium, CO2, creatinine, and then glucose forms the tail. And it always looks like this no matter who's writing it, no matter where they're writing it. Again, because you don't write out sodium 145. You just write 145. But because of where you put it, I know that that is sodium. So here you can see the fishbone with the actual lines. So again, it makes a little bit more sense where you have the tail at the end for glucose. And then below it you also have for your blood counts. Again, it's always in that specific pattern so that again, you don't have to write out, you don't waste time handwriting Na 145, Cl 100. You just put 145, 100, right, and just go quickly. Now we also have the comprehensive metabolic panel, or CMP. And so this is the basic metabolic panel plus an additional 6 to 7 labs, including albumin, serum enzymes such as alkaline phosphatase, AST and ALT, to look at liver function, total bilirubin, total calcium, and then you'll also see often ordered with this is going to be phosphorus, total cholesterol, and triglycerides. Now we'll start taking a look at some specific labs, and we'll start with BUN and creatinine. So BUN is blood urea nitrogen. So this is an end product of protein catabolism and measures the amount of nitrogen in your blood that comes from the waste product urea. Now we also have creatinine. So this is the byproduct of muscle breakdown. So again, here we have some specificity between protein and muscle. So they're both protein or nitrogenous products, but specifically creatinine, we're looking at muscle. This is filtered by the kidneys and excreted in the urine, and creatinine is a more sensitive indicator of renal disease than BUN. Now, both will increase in renal disease, but BUN can also be changed based on hydration status. Creatinine is more sensitive to renal disease. So here we can see the labs that we discussed in the BMP. Now, I don't need you to memorize these immediately. So the problem is that normal ranges, you'll actually see there's some variation. So you'll find different normal ranges depending on where you look. So I'm not real big on memorization. The problem is that, so for example, sometimes the sodium cutoff's 130, sometimes the sodium cutoff's 146, sometimes the chloride cutoff's 100. There's real tiny changes that, in the grand scheme of things, don't really make a difference. But you just may see there's a difference in Baycare's lab values, there's a difference in Advent Health's lab values, there's a difference in Orlando Health's lab values. So conceptually, they're all within decimals of each other, but again, I'd be more focused on interpretation. So the numbers I would put in my pocket guide just kind of as a reference, and then the decreased and increased factors, right? This is kind of why this is happening, is much more important. It's much more important that you understand if somebody has low creatinine levels, that they're having fluid overload, and then you start going, well, but why are they having fluid overload? Do they have a renal issue? Can they not excrete fluid? Did they consume too much fluid and there's a digestion or absorption issue, etc., etc.? So don't be too focused on the numbers. Spend most of your study time focused on the decreased and increased and why this is happening. And here we also have other electrolytes, your phosphorus, your magnesium, and your calcium. So these aren't part of the BMP, but again, these are often ordered, or you may often see these, especially when we start talking about looking at things like refeeding syndrome and some other acute conditions. So again, more important that you understand the why it's happening than the numbers. The numbers, there's always going to be a reference. The compute, look, it's 2020. When you look at the computers, they'll tell you, and they'll say, oh, his number was 2.9, that's low, right, for phosphorus. Or it'll say 3.0, within normal limits. So memorizing the numbers isn't so important. Again, please focus on the reasons for decreased and increased. And again, you don't have to memorize those by any specific date. It's more of, if I'm looking at study time, that's what I'm spending my time doing. All right, so we talked about this previously. We were looking at our CBC. So we looked at a few of those values, right? You had that fishbone that only had 4 values. But here we have the complete blood count. So this is going to include red blood cells, or RBCs, hemoglobin concentration, HGB, our hematocrit, HCT, mean cell volume, MCV, mean cell hemoglobin, MCH, mean cell hemoglobin concentration, MCHC, our white blood cell count, or WBC. And so again, we'll be looking at our differential, which indicates percentages of different kinds of white blood cells, so our ratio. Now here you can see the CBC, where again, you're going to have the normal range. You're going to have your reasons for decreased and increased, which you should focus on. Now I can tell you what I do with this is that I've created in my own mind what's known as a heuristic, which is kind of a mental shortcut for making decisions. You can see these lab values. Again, they're a little bit different for men and women, looking at total blood volume, looking at muscle mass, etc. But kind of in my head, the cutoff, right? Everyone's in trouble, and basically hospitals really start to do something if your hemoglobin hematocrit is 10 over 30, right? So if your hemoglobin's 10 and your hematocrit's 30, you're definitely anemic. The problem is let's say somebody is, 13-ish. That's fine for women and on the border for men, right? That's just below the threshold. And your cutoff is 42 to 50% for your hematocrit and 35 to 47 for women. So if you're in the low 30s or mid 30s, it's kind of not great. But again, at 10 and 30, most people are treating, right? You're going to be getting aggressive therapy. So again, I wouldn't focus on memorizing numbers, but if you kind of have this rough estimate of like, ooh, this is bad, they're going to be doing something about this. What's going on with this patient? then you're on the right track and you're in the right territory. Looking at stool testing, so fecal samples may be tested for the presence of blood, pathogens, and gut flora. Now we also have what's known as a fecal occult blood test. So obviously if there's significant bleeding, it's evident in the stool, but the occult blood test allows us to look for small amounts of blood that are not noticeable. And so this is ordered for adults over the age of 50 or younger adults with unexplained anemia. Often as one of the side effects, for example, of blood thinner medications is people will have GI bleeds, but they're not initially very noticeable, but the patient's still losing blood and may develop anemia. Stool cultures can also be done if there's prolonged diarrhea to determine if it's due to pathogenic bacteria. So again, if we're also trying to determine if it's a protozoan, bacteria, and usually not for viruses, because we don't really test the stool for viruses, but again, and because of the time of resolution, but again, something we could test for if necessary. So here we have, for example, of a urinalysis and for things that are looked for in the urine. So the big things you'll see, so specific gravity helps us with determining hydration, looking at pH, protein, which again should be in small quantities. There should be no blood or ketones or glucose in the urine. There should be no bilirubin. Again, you can see, so it doesn't really give us, unless there's the rest of the picture, but the urinalysis along with labs and other symptoms can kind of help us determine what's going on. So looking at hydration status, so dehydration, again, we're looking at negative fluid balance versus overhydration or edema when we have extra fluid, and so we have in the extracellular fluid. And so laboratory measures to determine hydration, and again, we're going to use these in combination with each other, so not any one value. We have to kind of look at the whole situation. Looking at serum sodium, BUN, serum osmolality, and urine specific gravity. So serum osmolality measures the concentration of chemical particles found in the blood. And so this is just a fancy way for telling us how much stuff is actually dissolved in the blood. And so to calculate osmolality, there is a formula. So that's serum sodium times 2 plus glucose divided by 18 plus BUN divided by 2.8. So I would make sure that you have this equation available, although most lab reports now will also automatically include the osmolality for you and will either say calculated or if it was actually measured. So looking at the assessment of stress-related protein energy malnutrition. So during inflammatory stress conditions, hormone and cell-mediated responses trigger the breakdown of lean body mass to synthesize cytokines, positive acute phase proteins, lactic acid, and white blood cells. And so what we need to do is we need to make sure that when we're interpreting lab values that we're doing this with caution, because again, because of these shifts from stress with these positive and negative acute phase proteins, plasma proteins may not accurately reflect nutritional status during these times of stress. Now again, we have our negative acute phase proteins, and these are things that decrease in times of stress. And this includes albumin, prealbumin, transferrin, and retinol binding protein. And there are others, but these are the ones that we're typically focused on. And positive acute phase proteins, again, this isn't a good thing. This is just the direction they go during times of stress. So here we have C-Reactive protein, or CRP, and fibrinogen. Now the other thing that's important to note is that the change in these proteins is proportional to the physiological insult. Which again, this is just a fancy way of saying that if someone is really stressed or injured, their albumin goes down a lot. If they're only a little stressed or injured, their albumin goes down a little. And same thing with CRP. If someone is injured or stressed a lot, then CRP goes very high. And if they are only stressed or hurt a little, then CRP only goes up a little. So looking more at these visceral proteins, so we have our C-reactive protein. So again, this is a positive acute phase protein, so this increases during times of stress. And it increases within 4 to 6 hours after the injury or illness. And we can use this to monitor the progress of the stress reaction to determine when aggressive nutrition support should be implemented. Again, what we don't want to do is add additional stress. We actually want that stress to peak and then kind of start to subside before we initiate nutrition support. And mildly elevated CRP may be a marker for increased risk of cardiovascular disease. So we'll talk about homocysteine and CRP are kind of our markers for inflammation and that chronic risk for cardiovascular disease. Looking at serum albumin, so we have our reference range at 3.5 to 5 grams per deciliter. Now the half-life is 3 weeks, so again, what we're not really using albumin for is looking at nutrition status, because whatever's happening in the body, right, that's your albumin is based on what happened to your body 3 weeks ago. So typically not what actually brought the patient into the hospital. Now it transports major blood constituents, hormones, enzymes, medications, minerals, ionized electrolytes, fatty acids, amino acids, and other metabolites. The major purpose, though, is to maintain colloidal osmotic pressure, so we'll talk about the maintenance of blood pressure. It is a negative acute phase reactant, so it decreases in times of stress. And albumin, again, as we said, is a mediocre indicator of nutrition status, but it's a very good indicator for morbidity and mortality. So the worse someone's albumin is, the more likely they are to be very sick or dying. Looking at prealbumin, so with a reference range of 19 to 43 milligrams per deciliter, has a half-life of 2 days. So again, whatever you did 2 days ago affects prealbumin. Now this is a negative acute phase reactant, so again it decreases in times of stress. And zinc deficiency reduces levels because zinc is required for liver synthesis and secretion of prealbumin. Now the average length of stay in most acute care hospitals is somewhere between 4 to 5 days. And so because of its short half-life, prealbumin is much more useful in monitoring improvements in protein status in hospitalized patients. Still not perfect because of its relation to stress, but if you come in on a Monday and I start changing your diet on a Tuesday, then by Thursday your labs should show an improvement. So if you don't leave till Friday and I draw your labs Thursday evening, Friday, I can see if the treatment was working before you're discharged. Looking at transferrin, so our reference range 200 to 400 milligrams per deciliter, a half-life of 1 week. Again, also a negative acute phase, so this will decrease in times of stress. Helps transport iron to the bone marrow for the production of hemoglobin. And when iron stores are depleted, transferrin synthesis increases. Now this responds too slowly, though, to be used in the acute care setting, but it can be useful in chronic monitoring. So if you're seeing somebody right over a period of several months, as they improve their diet, we're checking their labs, etc. Looking at retinol binding protein with a reference range of 2.1 to 6.4 milligrams per deciliter. Here we have a half-life of 12 hours. Again, this is also a negative acute phase protein, so it decreases during times of stress. Major function is to transport vitamin A, but it is unreliable when vitamin A status is compromised. Now, retinol binding protein is elevated in the presence of renal failure, regardless of if a patient is malnourished or not. So again, this is one of those you have to look at the whole picture, right? We can't just look at the lab and then immediately go, oh, they're malnourished, right? They could have other disease processes. So we have to look total picture with that critical thinking and not just at a single lab value. So creatinine is formed from creatine. So this is produced in the muscle tissue as a byproduct. And so serum creatinine is used along with BUN to assess renal function. So muscle meats are rich sources of creatine, and so when following a meat-restricted diet, the body's muscle protein pool is directly proportional to urinary creatinine excretion. So again, you can produce some creatine endogenously, but you can also consume it exogenously from food. So we see those people with high protein diets or that exercise a lot are going to have this elevated creatinine, right, from this breakdown in muscle tissue. Now, one of the ways we can calculate creatinine, so skeletal muscle mass in kilograms, we can determine this is looking at 4.1 plus 18.9 times 24-hour creatinine excretion, and we can actually work backwards and see. So based on how much tissue is being broken down, we can figure out actually how much muscle mass the patient has. Now, this does require, though, a 24-hour urine collection, which is difficult to manage except in hospital settings and usually with a catheter. So we also have our nitrogen balance studies. So this is the oldest biochemical technique for assessing protein status. Now this is based on the fact that 16% on average of protein is nitrogen. And so this translates to there's 1 gram of nitrogen in every 6.25 grams of protein. So nitrogen intake is then compared to nitrogen output, and then this is adjusted for insensible losses such as sloughing from the skin, hair loss, sweat, etc. Now, what we should see is that most people should be in a neutral nitrogen balance, right? So it should be 0, which is this many grams in, this many grams out. Positive nitrogen balance occurs when we are increasing protein in the body or increasing muscle, growing, etc. So this is things like growing children, pregnant women, people gaining weight or recovering from injury or illness, right, or regaining tissue. Negative nitrogen balance is when we are losing more protein than we are eating. And so if we are breaking down or losing protein, this is negative things like starvation, catabolism, protein, energy, malnutrition, etc. Now here's the actual equation. So for nitrogen balance, it's nitrogen intake in grams per day minus urinary nitrogen minus 4 grams, which is that non-urinary losses. So this is going to be, again, that skin, hair, sweat, etc. is estimated to be about 4 grams per day. And for nitrogen intake, again, you take your total protein per day and then divide it by 6.25. Now some of the challenges with nitrogen balance studies. So urea nitrogen is highly variable as a percent of total nitrogen excreted. It's nearly impossible to capture an accurate nitrogen intake for patients taking food PO or orally. So if somebody's eating food and we were to run this study, I have to weigh all of your food, look at how it was cooked, what brand it was, right, to really make sure I have an accurate picture of how much protein was going in the body. This is a little bit easier if I'm using things like tube feeds, TPNs, etc., as that's a predetermined amount of protein. 24-hour urine collection may be difficult and tedious, so unless the patient has a catheter, it can be difficult to make sure that we are not missing any of the urine specimen collection, especially right if people have to urinate in the middle of the night. It's very easy to forget to collect the urine, and the entire study is useless, and we have to start over. So this is most useful, though, in evaluating the appropriateness of defined feeding, such as IV or enteral feeds. And again, you'll see it a lot in research studies to then determine the accuracy of either an equation, a meal, calories, etc. So here you can see those proteins that we were discussing. So here again, you can see the ranges. And again, what I would focus on is the reasons for the decreased and increased values. Looking at laboratory data to assess anemia, so we'll go in depth. You'll see later this term will actually discuss anemia in depth. So this is just kind of the overview. And so anemia is a symptom of many diseases and results from extensive blood loss, blood cell destruction, lack of blood cell formation. But it's important for clinicians to determine if anemia is caused by nutritional inadequacies or by other factors. Because again, we can treat the nutritional issues, but if it's not nutrition, there's not much we can do about it. The medical and the healthcare team can do about it, but not much that we can do as dietitians. And so nutritional deficits can cause decreased hemoglobin and red blood cell production. So to assess anemia, we look at red blood cell volume, or MCV. So if it's less than 80, then the anemia is considered microcytic. If it's 80 to 99, that is normocytic. And if it's 100 or greater, then it's macrocytic. So you've got small blood cells, normal blood cells, and large blood cells. So microcytic anemia is most often associated with iron deficiency. Macrocytic anemia is generally caused by either folate or B12 deficient erythropoiesis. And normocytic anemia is associated with anemia of chronic and inflammatory diseases and does not respond to iron supplementation. Normocytic or microcytic anemias may be caused by chronic or acute blood loss, including surgery, occult blood tests, and injury. So for example, right, if a patient's in a motor vehicle accident and loses a significant amount of blood, we of course are going to get their lab report and see that they're anemic. But you know, they don't really need more fruits and vegetables and red meats. What they need is a blood transfusion because they were just in a car accident. So again, it's not that nutrition can't help, and it's a nice ancillary treatment to make sure, of course, this person's getting well nourished, getting their macro and micronutrients to recover. But the truth of the matter is they need a blood transfusion. Macrocytic anemias, we have our megaloblastic anemia or folate deficiency, and pernicious anemia, which is B12 deficiency. Now, tests for iron deficiency anemia, we look at hematocrit, which is measuring percentage of red blood cells in the total blood volume. Now, this can be thrown off, though, by hydration status. We also check hemoglobin, which measures the total amount of hemoglobin in the peripheral blood. So we're looking at protein in the red blood cells that can specifically carries oxygen. And this is a better indicator than hematocrit, but especially if we have both and we have a background, we again have kind of a better understanding. So when both hemoglobin and hematocrit are below normal, right, we're going to see this in nutritional anemias that we can kind of dive deeper into and how we're going to treat them. Looking at serum ferritin, so this is a storage protein for iron. And so as iron supply increases, ferritin increases to increase the iron storage. So this is a positive acute phase protein, so it's going to go up in times of stress. Not a reliable indicator of iron storage, though, in patients with acute inflammation, metastatic cancer, or alcohol-related liver disease. And if iron deficiency exists during acute illness, it might not be diagnosed because we'll have artificially elevated ferritin levels. So you kind of have this wacky scenario where the labs look good because of the stress, but we actually don't have the correct amount of iron. Looking at serum iron, so it measures the amount of circulating iron that's bound to transferrin. Relatively poor index of iron status because of large day-to-day changes, even in healthy individuals. And we should evaluate serum iron along with other laboratory values to get a better overall picture of iron status. So again, this is why we talked about previously in the slides about functional versus static assays, because again, sometimes things like this don't really give us the most accurate picture, so we will also use those functional assays to better understand, in this case, iron status. We also have total iron binding capacity. So normal levels are below 250 to 400, and this measures the maximum amount of iron that can be bound to transferrin for transport. And so iron binding capacity and transferrin increase with iron deficiency anemia. And so it's sometimes a little counterintuitive, but the example I always use is like if your pet runs away. So if Rover the dog runs away. If you were trying to find Rover, and Rover is an iron molecule, if you send one person, right, so you have one molecule of transferrin or a low iron binding capacity, right, you're looking for one person to go find Rover. But instead, when you're looking for one person, you send out a whole bunch of people, right? You send out a search party. So then you have 10 people looking for Rover. This is the same thing. Iron binding capacity and transferrin go up because you're sending out a large search party of 10 people to go and find the one iron molecule. Looking at tests for macrocytic anemias. So we'll talk about serum homocysteine. And so this is elevated during B12 or folate deficiency. And so homocysteine can be recycled into methionine or converted into cysteine with the aid of the B vitamins, B12, B6, or folate. And folate, we're measuring total red blood cell folate because this is a better indicator of folate status than serum folate. So again, you have to make sure you're reading that lab panel correctly. So total red blood cell folate concentration is the difference between folate in whole blood and the folate in serum alone. And folate is absorbed in the jejunum, so again, if we're suspecting malabsorption, etc., right, we have to also find the cause of the folate deficiency. Looking at B12 deficiency, so this is measured in the serum. So B12 is absorbed in the terminal ileum, so the end of the ileum. Decreased intrinsic factors or parietal cells often cause decreased B12 levels. And we use the Schilling test to detect defects in B12 absorption, but this is rarely used because it requires a radioactive form of B12. And so it's much easier, for example, we can just look at how a patient's body responds, which is I can measure GI acidity, or I can give you B12 injections, and if you respond positively, then we've pretty much found our solution. We'll also take a look at MMA, or methylmalonic acid. So this is formed during degradation of valine and odd chain fatty acids, and B12 is a cofactor needed for this reaction. So B12 deficiency causes an increase in MMA in the body. So here we can see our iron status labs. Again, you can see the numbers, but I'd be more focused on the decreased and increased causes. Again, so what you're looking for is why is this happening, or which patients this will happen in. Looking at the fat-soluble vitamins. So fat malabsorption often results in impaired absorption of vitamins A, D, E, and K. And individuals who have had bariatric surgery are at the greatest risk for fat-soluble vitamin deficiencies. So vitamin A can be estimated by measuring serum retinol. So the normal level is 30 to 80 micrograms per deciliter, and toxicity is associated with levels greater than 100 micrograms per deciliter. Vitamin D can be estimated by measuring plasma 25-hydroxy vitamin D levels, and so a deficiency is less than 30 nanomoles. And vitamin K is estimated using prothrombin time, which measures clotting time. And so this is an excellent example of a functional assay where I don't actually measure your vitamin K levels. I measure how fast your blood clots. Because if you have the correct amount of vitamin K, then your blood will clot in the correct amount of time. Looking at lipid profile and cardiovascular disease. So what you'll see is that often they tell you that you should, don't eat anything after midnight, or make sure you're fasting when you come in for your labs. But to truly do this right, patients should be fasting for 12 hours prior to their assessment. So if you're going to have your blood work done at 7 in the morning, you really shouldn't eat anything after 7 at night, the night beforehand. And a lot of times people think, oh, like I have until midnight. No, you didn't, right? We're looking at a much larger window than sometimes people realize. Now, the risk for cardiovascular disease appears to be more related to the number of atherogenic lipoprotein particles in serum than to the total volume of cholesterol. And so LDL contains the atherogenic apolipoprotein B, which is the one we're most concerned about. B is for bad. So LDL, so elevated levels of LDL is atherogenic. VLDL, the remnants from it, are atherogenic. High levels of triglycerides appear to be atherogenic. And CRP, so elevated levels without inflammatory status, again, this is that quote-unquote chronic mild inflammation. So CRP should go up if you've been injured, stressed, etc. It should then go back down to normal. If it doesn't, that's bad, and that's long-term increases your risk of cardiovascular disease. Serum homocysteine, again, increased levels related to increased cardiovascular disease risk. So again, here you can see the lipid profile. So you can see cholesterol, triglycerides, HDL, and LDL. Again, you can look at what increases and decreases these. But again, remember, our major focus is on their ratio and not so much absolute numbers. Looking at diabetes. So we're usually looking at hemoglobin A1C, or glycosylated hemoglobin. And so this is the percent of glycohemoglobin in the blood, as it's directly related to the average blood glucose over the past 2 to 3 months. Now this is a very unscientific explanation, but this is kind of like when they take dolphins or other sea creatures, right, and they put a tracker on them. What happens is when your blood cells are exposed to large amounts of sugar or glucose, in essence they get a tracker tag on them. And what happens is we can find out how many blood cells have tracker tags on them, and this tells us how much sugar or glucose has been in your blood. Now what happens is, and this is over the last 2 to 3 months, giving us kind of an idea about your compliance with the diet and medication, is that blood cells will die off and be replaced. So if you start taking care of your blood glucose better, the blood cells that have tracker tags on them will die, be replaced by new blood cells without tracker tags, and then what we'll do is we'll be able to remeasure your hemoglobin A1C and see that your blood glucose has gone down. Now we can then, the problem is most of the time your patients are going to say, well, I don't know what that means. Like I know my A1C is bad, but like what does that mean? So we can calculate average blood glucose from A1C. So if, for example, if somebody has an A1C of 7, right, we would then say 7 times 33.3 minus 87. And that would tell us that their average blood glucose was in the 145s, 150-ish. So then when you tell the patient, oh, well, your blood sugar's been in like the 140s, probably low 150s, and they go, oh yeah, that's exactly like, that sounds like my glucose monitor, and you go, but that's not good, we need to fix that. Or, right, so again, it's a number they can relate to much easier. So again, you'll make sure that when you're talking to your patients that you're not talking over their head and you bring it to a level of their understanding. So here you can see the glucose and A1C, and again, we can see changes that would increase or decrease these values, especially in the short term. Looking at thyroid function, So one of the things we look at is TSH, or thyroid stimulating hormone. And I'll give you one guess what this does. If you guess that it's what stimulates the thyroid to produce hormones, you are correct. Now in this case, right, this is a static assay, so we're just measuring the actual amount in the blood. This is produced by the pituitary, and this is what's actually telling the thyroid to release hormones, right, and then produce hormones and release them into the blood. Now then the actual thyroid hormones themselves, we have T3 and T4. And so you're probably familiar with, right, this is when we quote unquote take a look at metabolism or weight gain, etc. So again, we've got, again, we have T3 is most involved in metabolism, and then T4 is considered our major hormone secreted by the thyroid. Now here again we have our levels, but and what's important is that we have our free T4 as well as our total. So again, if you're just hearing about T3 and T4, make sure you're looking at the panel carefully to see if it's free T4 or total T4. Looking at renal, we have our glomerular filtration rate, or GFR. So this is used to check how well the kidneys are working, and so specifically it estimates how much blood is passing through the filters in the kidneys per each minute. Now older people will have a lower GFR, so GFR does decrease with age, right? It's like anything on an old car, it starts to wear out. But a GFR below 15 milliliters per minute per 1.73 meters squared is a sign of kidney failure and requires immediate medical attention. And we'll talk more about the specific stages of chronic kidney disease and how it progressed to this stage 5. But you can see it's just kind of a weird, when you look at the units on it. So milliliters per minute per a surface area. So if we were in essence to unravel or turn the kidneys into a big sheet, right, they're kind of like a really, really squished coffee filter. You can imagine, right, 1.73 meters squared. So there's a lot of filtering going on inside that tiny space inside the kidneys. So here we can see our diagnosis for, again, from no kidney disease down to that stage 5, which was less than 15, which again requires immediate medical attention. So taking a look at the pancreas, remember it does more than produce just insulin. So here we're actually going to look at digestive enzymes. So amylase, remember, is the enzyme that helps us digest carbohydrates, and so this is produced in the pancreas as well as in the salivary glands. Now when the pancreas is diseased or inflamed, we'll actually see amylase levels increase in the blood. And similarly with lipase, which again is released by the pancreas into the small intestine to break down fat, again we will actually see lipase levels increase in the blood when we have a disease or inflammation of the pancreas. So here you can see these levels, and I have seen unbelievably high. I mean, I have seen them in the 1200s. I've seen some of these enzyme levels, which is pretty wild, and some pretty damaged pancreases. Looking at the liver, we have our liver function test, or what you'll commonly hear is the doctors will say, what do their LFTs look like? And that's going to be your AST, ALT, alkaline phosphatase or ALK-Phos, bilirubin, and ammonia. So ALP or ALK-Phos is alkaline phosphatase. This is a protein found in all body tissues, but high amounts of ALK-Phos can be found in the liver, bile ducts, and bone. So if they're damaged or being broken down, you'll see them increase in the blood. You have your AST, which is your aspartate aminotransferase. This is found in high amounts in the liver, heart, and muscle cells. So again, high levels in the blood indicate that the liver, heart tissue, or muscle cells are being broken down. And ALT is your alanine aminotransferase. And this is found highest in the amounts in the liver. And so injury to the liver, again, increases the amount of ALT in the blood. In most types of liver disease, the ALT level is higher than AST, and the AST-ALT ratio will be low. Now, the exception for the AST-ALT ratio is usually increased in alcoholic hepatitis, cirrhosis, and with muscle injury. And that's why, again, we have to look at these in context and the whole picture, is because these labs usually are used as indicators for liver function and health, but they can be, for example, things like muscle injury, cardiac injury. So you need to look at the patient as a whole and not one individual lab or symptom. So here we have our reference ranges, and again, what I'd focus on is our reasons for why. We also have bilirubin. So this is the yellowish pigment found in bile, And so this is made by the liver. Now you'll also see, so bilirubin is what gives bruises their distinctive color when they go from the color of blood cells, which is that reddish purple, to when they turn that yellow green. That yellow green is bilirubin. We can also check for ammonia or NH3. So this is produced by cells throughout the body, especially the intestines, liver, and kidneys. And most of the ammonia produced is used by the liver to produce urea. So remember, ammonia is highly toxic. So the liver will then break this down into urea, which is slightly less toxic, to protect the body. And this is most commonly used to diagnose and monitor hepatic encephalopathy, which is a side effect or a condition secondary to severe liver disease. In essence, the patient's brain is being poisoned by this ammonia in the blood. So here again we have our ranges and again our causes. So again, we've talked about vitamin K a little bit, but looking at our clotting time, so we have our PTT, which is our partial thromboplastin time. And so this is a blood test to look at how long it takes for blood to clot. This can help determine if there's bleeding or clotting disorders. And clotting can take up to 2.5 times longer if a patient is on blood thinners. And so again, if they're getting a therapeutic dose of that medication, right, what we're going to be looking at is then they're going to have adjusted lab values for what's acceptable. Then we have our prothrombin time. So here again, this measures the time that it takes for the liquid portion or plasma of the blood to clot. And again, PT is going to be longer in patients with blood thinners. So PTT and PT are both looking at clotting, but technically we're just looking at different portions of the blood and how quickly they're clotting. You also have the INR, or International Normalized Ratio. And so this is a formula that adjusts for differences in the chemicals used in labs, so the test results can be comparable. And so what will happen is, if you have, a Quest Diagnostics versus LabCorp, etc., right? Technically, they're using slightly different chemicals, and so this lets us have everybody on the same playing field. So if INR is high, then blood clots more slowly than desired, and if INR is low, then blood clots more quickly than desired. And we're monitoring INR for people on these oral anticoagulants, so this Coumadin, Xarelto, etc. It's not really useful, and it's not really used when PT is higher for other reasons, right? This is our standardized measurement for looking at the safety and if people are in a therapeutic range for their blood thinners. Again, we talked about vitamin K, and we know that it's involved in clotting. And so if serum vitamin K levels are low, then clotting is impaired. Now there's two different ways we can get vitamin K. So we can get it from foods and supplements. So it's typically from leafy greens. So this is going to be your kale, your collard greens, your mustard greens, your spinach, etc. But mostly we're also going to get it from a symbiotic relationship with bacteria in the GI tract. And so what happens is it's a byproduct of their metabolism. But in this case, right, because we have a symbiotic relationship, is that we keep the bacteria in our gut alive, and in exchange, we actually absorb the vitamin K that they produce. Now here again, we can see our PTT and our PT numbers. Again, we can see there's changes in foods, right, which is what we're most focused on for our increased causes. So again, that's one of the things with things like Coumadin or warfarin, right, so brand name versus just generic name, is what we're looking at is that, quote unquote, it's reversible, which is if I give you certain foods, you can actually reverse the status of the medication. Here you can see INR and vitamin K. All right, so some practice questions. So serum proteins that decrease during the acute phase response. So they decrease, these are our negative acute phase proteins. So which proteins are negative acute phase proteins? And this is A, albumin, transferrin, and retinol binding protein. Number 2, acutely ill patients experiencing inflammatory stress would be expected to have high serum levels of, and so with increased stress, we will see answer choice D. This is C-reactive protein. Number 3, anemia caused by deficiencies of folate or vitamin B12. So this results in cells that are answer choice A, macrocytic, or larger than normal. And the Schilling test is used to and this is to detect defects in vitamin B12 absorption. Now remember, this test is rarely used because of the radioactive B12. This requires a specialized lab to handle and monitor, but again, this is for B12 absorption. And number 5, interpretation of laboratory data may be complicated by and if I almost tricked you, it's answer choice D, all of the above. Dehydration, inflammation, and the stress response can all influence lab values and their interpretation. Now you will see several scenarios involving labs. So I would encourage you to review these before our Zoom session. So we will be going over these scenarios, and the skill we're looking at practicing is that basic interpretation of what is probably going on. Now again, we don't have all the background information, you don't have the whole picture. Again, what we're looking for is the first impression, right? So one of my favorite phrases is, when you hear hoofbeats, think horses, right? We're just looking for what's the most obvious thing, what's it probably gonna be. Right, we're not going to look for anything strange. We're not going to assume, well, if this, and this scenario happened, this might happen. Just, hey, if they've got high blood sugar, they probably got diabetes. Okay, that's what this means. They got high blood sugar, something's going on with their blood glucose management. So, again, just take a look at these scenarios, and like I said, we will discuss them during the Zoom session, and again, looking at kind of these interpretation of these numbers. So take a look at those. I thank you for your time, and I look forward to your questions.